Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. This is a clinical EKG interpretation, chapter 14, part 2. Here we're going to be looking at calcium, magnesium, hypothermia, and much more. So let us begin with the feature presentation. Chapter 14 has a number of items. In the part 1, we covered stress test, voltage, EKG, and potassium changes. In this presentation, we are going to be talking about hypercalcemia, hypocalcemia, hypomagnesemia, hypothermia, cardiac transplant, hyperthyroidism, muscle tremors, and much more. So let us look at the changes of calcium on the action potential and also electrocardiographic features. Hypocalcemia is defined as a calcium level of less than 8.5 milligrams per deciliter. Hypocalcemia results in prolonged ST segment, prolonged QT interval, and it can also precipitate torsade. If you look at the action potential, the role of calcium comes during phase 2, as we can see here, and part of phase 3, where the calcium influx results in slow repolarization of the myocardial cell. Whenever there is a decrease in calcium, there is prolongation of the ST segment related to prolongation of the action potential. On the other hand, hypercalcemia is characterized by a calcium level of 10.5 milligram per deciliter. It is characterized by shortening of the ST segment and also shortening of the QT interval, resulting in a classic Osborne sign. Osborne sign, there should be an E here, apologize for the typo. Osborne sign is not only seen in patients with hypercalcemia, it can also be seen in patients with hypothermia. Let's look at from an action potential point of view. When there is excess amount of calcium in the extracellular space, there is more influx of calcium, resulting in rapid repolarization, leading to shortening of the ST segment. So much for the chemical analysis of EKG changes noted in patients with hypercalcemia and hypocalcemia. So let us look at some examples and see what we can learn. Here is an electrocardiogram, and what is your diagnosis? I think the most obvious thing is a shortening of the ST segment with a rounded top, resulting in an Osborne wave, and this is a tracing from a patient with hypercalcemia whose calcium level is probably in the range of 10 or greater. The regular treatment for the treatment options available for hypercalcemia include calcitonin, glucocorticoids, supplemental phosphate. It is important to know some basic things about treatment of hypercalcemia, because the questions may be intermingled with EKG changes, clinical findings, and treatment as such. So let us move on, and here is a tracing. What is your diagnosis? First, identify what is an obvious finding in the electrocardiogram, and then try to correlate that with the clinical condition. The most obvious thing that you see is a prolongation of the QT interval. If the QT interval is greater than 50% of the RR interval, then you have prolonged QT interval. And when you see prolonged QT interval, the next thing that should come to your mind is that prolongs the action potential. Just as I discussed at the beginning, the prolonged action potential is seen in patients with hypocalcemia. So always keep in mind prolonged ST segment with a long QT interval, you should suspect hypocalcemia. Of course, there is a long QT interval syndrome, which is a genetic abnormality, and that's totally a different issue altogether. Let's look at this one and what is your diagnosis. Okay, this is an example of hypomagnesemia or low magnesium. What are the things we see here? We see some low voltage in the chest leads. We see a sinus rhythm. Again, we see a prolonged QT interval with a very short TP interval, which is pretty obvious. And here are some of the findings. Normal magnesium level is 0.8 to 1.0 millimoles per liter. Low magnesium can result in premature atrial complexes and premature ventricular complexes, and the characteristic feature would be prolonged QT interval. And of course, this can be easily treated by giving 1 to 2 grams of magnesium in 100 cc saline infused over 1 to 2 hours. So always keep in mind hypomagnesemia when you are dealing with a long QT interval. Okay, what is your diagnosis here? Most important thing is, if you look at the P wave here, there are 2 P waves here. So we have notched P wave. We can see notched P waves in a variety of conditions, especially with the patients with right ventricular hypertrophy, right atrial enlargement, or patients with tricuspid stenosis, pulmonary hypertension. But here, the more obvious thing, we have C2 P waves, and of course we have a right bundle branch block, and this is a case of a cardiac transplant with right bundle branch block. In addition to that, we also see some low voltage, which may be related to perioperative conditions and some non-specific STT changes. The tip off here is, if you see a notched P wave with 2 spikes, think about, and if the voltage is not significantly high, as you see in patients with pulmonary hypertension, tricuspid atresia, or any other conditions that raises the right atrial pressure, then think about cardiac transplant. There is the arrow there. Okay, hypothermia. Hypothermia sort of mimics the picture of hypercalcemia. You see the short ST segment with an Osborne wave with a downsloping T wave, inverted T wave, and these are some of the features of hypothermia, short ST segment. Other features of hypothermia include the notch on the QRS complex, Osborne waves. P waves may be flat along with T waves. So P and T waves could be flat, low voltage, prolongation of P or QRS and QT intervals, bradycardia, junctional bradycardia, atrial fibrillation, high degree blocks, muscle shakes, and ectopic beats, or even VTAC or VFib. So that is a serious condition which has to be addressed in a expeditious manner. Hypothermia EKG changes are seen in 85% of the people when the temperature drops below 35 degrees Celsius. Similar changes may be seen in patients with hypercalcemia, which I already talked about, and the J waves are usually seen in lead 2 and V2 to V6. It may also be seen in patients coming off cardioplegia during cardiac surgery. Is your diagnosis here? Well, we see something interesting. There is a prolongation of the QT interval, and there is also a notch here which may represent perhaps a U wave, a fusion of T and U waves, flat ST segment. So this is an example of a long QT syndrome. And here is a tracing showing various effects of digitalis on the electrocardiogram. We can see a J-point depression, downsloping ST segment, blending with biphasic T waves. So these are some of the important features of digitalis toxicity. In addition to that, we can have ectopic beats and many other conditions. We can have a sinoatrial block. We can also see sinus bradycardia or pauses. We can see various degrees of heart blocks, first degree, second degree, and even third degree. We can see short QT interval. Of course, ectopic beats coming from atria or ventricles. It can also lead to ventricular tachycardia if it's associated especially with electrolyte imbalances. It can result in paroxysmal atrial tachycardia with block, which is supposed to be diagnostic of digitalis toxicity. In addition, high levels of digitalis may be associated with junctional tachycardia. So let's keep that in mind. So what is your diagnosis here? I mean, obviously we have an inverted P wave here. We have a QRS going downwards. So we have a right axis deviation. And we have loss of R waves in the lateral chest leads with more prominent R waves in the anterior leads. Everything seems to be reversed here. What do you think? Yes, you are right. It is dextrocardia. If something looks reversed, then think about dextrocardia. This is a cartogenous syndrome. This is a cartogenous syndrome characterized by rightward axis, loss of R waves in the left chest leads, and always if something looks reversed, think about dextrocardia. Here's a chest x-ray showing an example of a dextrocardia and the same electrocardiogram here. All right, here's another example of a dextrocardia with the right axis deviation, an RSR prime here, but loss of R waves in the lateral chest leads. Okay, what is your diagnosis here? We have a right axis deviation here. We have a right ventricular hypertrophy here and STT strain. Whenever you see a right axis deviation and a right ventricular hypertrophy, we start to think about congenital heart diseases like atrial septal defect, ventricular septal defect, or a tetralogy of Fallot. Well, we see right atrial deformity because of the prominent P waves here, right ventricular hypertrophy, STT changes with the peak P waves. So this is a case of right ventricular pressure overload, which could be seen in patients with the tetralogy of Fallot. Here's an example of an artifact which can mimic atrial fibrillation or atrial flutter. Artifact. But the RR intervals are pretty constant. Of course, you can see in a patient with digitalis toxicity a constant RR interval in a patient with atrial fibrillation, which can look like this. But we have to look at the whole clinical picture. Okay, this is known as the 60 cycle. As you can see, there is 40 milliseconds, every 60 milliseconds, there's a spike, and this is usually due to electrical interference. If you pull the plug out and put it in a different socket, you may be able to get rid of these 60 cycles. Appearances can be deceptive, but you have to look beyond the clouds. You have to look beyond the deceptive points. Let's march the QRS complex here. Here's a QRS, here's a QRS, here's a QRS, here's a QRS. Here's a QRS. We have a regular underlying narrow QRS rhythm with a rate which is fairly around 80, 75 to 80. What's going on here? So look at these undulating waves. They are not making no difference in the electrical rhythm. When you see this, you should think about Parkinson's disease that can lead to muscle tremors that produces an electrocardiogram like this. Somebody tried to trick you by saying it is 60 cycle interference, but it is muscle tremors most likely related to Parkinson's disease. So ladies and gentlemen, that concludes chapter 14, Miscellaneous Conditions, from my clinical EKG book. We have all the other chapters covered in this EKG book playlist. Take time to listen to them so that you will be well informed about how to interpret EKGs in the emergency room, in the intensive care unit, or when you are in surgery dealing with an abnormal electrocardiogram. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel. We will see you next time.